So the only thing that's missing so far is housekeeping. So in case of a fire, we have some fire exits at the back, the ones you came in, and we probably have some fire extinguishers somewhere, and there's probably a fire alarm. If all else fails, panic. And remember, I'll be out before you. Okay, so my name is Richard, and I'm the chair for this afternoon. Now, I've been a podiatrist for 30 years, both in the NHS and in private practice. I have a practice in the UK with a team of 6, but now I work alongside Fabian at his practice in Nairobi. When back in the UK, I work for a charity providing emergency medical care at large festivals, including Glastonbury, where I will be in a few weeks. So, let me just... Unfortunately, despite the best and very brave efforts of the firemen that night in Bolton, including my father-in-law, the building was devastated by the fire. DFUs are also devastating, and despite our best efforts as clinicians, the odds are often stacked against us. So, what do we do about this? Prevention. As we all know, we all know about fire prevention and what to do in the case of a fire. Hence my speech at the beginning. Every time you get on an aeroplane, we have it repeated and repeated. It's the same with DFUs. Diabetes doesn't care. Young, old, rich, poor. So if we can do anything to improve our patients' outcomes, it's worth the effort. So today we're going to look at some processes and strategies that will hopefully give you as clinicians a better understanding of what to do, because once we've seen the buildings on fire, it's often too late. Right, we have a pre-test for you. So if you would like to try and download this QR code, is it on the table, Doctor? No?
I'd like for you to scan this QR code.
Thank you.
Maybe you can open up Google Translate, the main Google page. I hope most of you are able to access it. Or maybe you can do it as a table if you'd like. Do you want to make a competition out of it? Yes? I heard 1 or 2 yeses. No, 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 not yet. Okay. The tummies are still full. Postprandial hyperglycemia setting in. You have 1 more minute to go. Who wants a prize? Oh, just the 1 table. So maybe just the 1 table will get a prize. Shall I do fastest fingers first? It's good. So we already have a couple of prizes already accounted for. Okay, do you want another minute? Yes, 1 more minute? Okay. These are very simple questions. There is no exact right or wrong answer. It depends on the setting that you have and the approach that you take to diabetes-related foot problems. We are to focus mostly on foot care this afternoon. It's not something that everybody wants to do. Smelly feet is not everybody's cup of chai. That's definitely Fabian's cup of chai. It's his bread and butter and jam and Marmite and... Repeat that, Fabian.
Delicious.
15 seconds. Okay, and time is up. Thank you very much. You can go ahead and continue to answer them. In the meantime, I'd like to hand over to Dr. Fabian Collis to continue the workshop for today.
Thank you very much, Dr. Shilpa. I'm taking this up because KPLC is very good at the moment, so I'm going to make sure that I can actually see. Right, I'll just put it there. Okay, welcome everybody, and I am, like Richard said, thank you for the introduction, the father of podiatry. Some people call me the grandfather of podiatry. I certainly look older now than I've ever done. I've lost all my hair and my feet hurt all the time. So anyway, I'm going to talk to you a little bit about, so let's put the, so we can do this. Let me just start. We need to put the pointer. So, right. Right, so my topic today is I'm going to briefly introduce the diabetic foot, and I'm going to talk to you about what it involves, and then we will start doing a practical session. So I'm a consultant podiatrist. I've been around a long time. When I came to Kenya, podiatry wasn't even heard of. It's taken a long time to have podiatry recognized in Kenya, and finally we are now a recognized and registered profession within the Kenyan healthcare system and framework. So that is really, really good. So just talking about, sorry, these pointers have neuropathy, so I will try to, yeah, I don't think it's working. Hi guys, is there a, yeah. Okay, severely neuropathic, don't know why it's not working. Okay, there we are. So let's talk about a little bit of foot facts. 1 in 11 adults has diabetes, or is a person living with diabetes. 80% of diabetic patients will have peripheral neuropathy. 1 in 7 people with diabetes will develop a foot ulcer, and 85% of amputations are preceded by a foot ulcer. Diabetic foot disease poses a significant economic burden, whereby Kenya it costs around 2,000 shillings to examine a foot for diabetic complications. If you end up developing a DFU, this goes up to 5,000 to 10,000 shillings. If you end up in hospital with a diabetic foot complication, you're now spending in a hospital like MP Shah or Aga Khan or Nairobi, you're looking at 15 to 30,000 shillings a day for inpatient care. This goes up if you require an amputation to 200 to 500,000 shillings. And if you end up having a vascular surgeon look at it and remodeling and revascularization of the foot, this goes from 80,000 to almost 2 million shillings. So you can understand why it is one of the most expensive diabetic complications to manage once people start developing diabetic foot complications or problems. Almost a quarter of people die within 30 days, and almost half at 1 year, and 80% within 5 years. The survival rate after lower limb amputation is lower than that of common cancers. Okay? The average person takes around 8,000 to 10,000 steps a day, which adds up to around 115,000 miles over a lifetime. That's walking around the circumference of the Earth 4 times. Okay? So, okay, this could take 3 days. Sorry about that. So survival rate after lower limb amputations, after 30 days, 78%. 1 year, it's 56%. And look at that, after 5 years, your survival rate goes down to 23%. Okay. So when we talk about understanding the diabetic foot, major complication of diabetes mellitus, it's a triple jeopardy. So we're looking at neuropathy, which is poor sensation and nerve damage. We're looking at ischemia, which is poor blood flow, PAD, and we're looking at infection. Okay, and often an itchy, painless lesion appears on the foot, which eventually leads to a flood of complications. Of course, patients dread the dread of disability, and if you're the breadwinner in the family, this is a serious issue, and also very expensive long stretches in hospital. Okay, and we look at the triage effect. So you look at trauma because of neuropathy, which leads to a DFU, which can also lead to a porthole of infection to enter, which leads to infection, and as a result, because of that, you have poor healing, or PAD, ischemia, and you don't heal properly. Okay. Right, so this is just a simple slide that talks about the pathophysiology of the diabetic foot. Neuropathy, there are 3 types of neuropathy. Motor changes. So what happens in motor changes is you end up with muscle weaknesses, particularly in the lumbrical region, which then leads to deformity of the foot, which ends up as abnormal stresses in the foot, high plantar pressure. So what happens is when you often see with patients who tell you, oh, I didn't have high arches when I was younger, but now I'm developing high arched feet, because your foot pressures are changing. This then leads to callus formation, which eventually results in diabetic foot ulceration and can lead to amputation. You've got sensory. 85% of your patients will possibly have sensory or loss of protective sensation. In the insensate foot. So basically patients can feel. What I'd like you to do now is you've got something on your thing. There's little bits of paper on your table. Can you, everyone, just put that in your shoe, please? So just take 10 seconds. There's a little bit of paper. Stick it in your shoe, please. I want everybody to stuff that in their shoe. Okay? And if you're wearing chappals or sandals, then you're lucky. You don't have to do it. But anyone who has proper shoes, please stuff that in your shoe. Okay? Has everybody stuffed a piece of paper in their shoe? Right, now stand up. Now stand on one leg, the one that's got the piece of paper in it. Okay, and I'm going to talk for another minute or 2 on this slide, and you're all going to stand there on one leg. All right? Okay, so let's talk about that. So it results in trauma, which then leads to also vascular disease, right? So microvascular disease. So microvascular is the small little vessels at the end of the toes, which becomes damaged at the basal membrane, which then lead to ulceration and eventually lead to ischemia and amputation. Macrovascular disease is when what happens is you get damage to the arterial walls, which then eventually lead to narrowing of the arterial walls. And the way I describe that, that's like putting one hose pipe inside another, inside another, inside another, and eventually you end up with poor blood flow, which results in ulceration and amputation. Okay, you may sit down now. Now tell me something, was that difficult? Yeah, was that, now imagine your patients with an amputation. And remember that most of your patients will not be able to feel that piece of paper in the shoe. It's bloody irritating, isn't it? And you will all be taking it out in the next 2 minutes. But your diabetic patients don't notice that. They don't feel that. So they can walk around with a stone in their shoe all day, not necessarily removing it, and eventually it leads to an ulceration. And then because of poor healing and ischemic complications, they don't heal. Yeah. Right, okay, so let's talk about assessing of a foot. Now, quite simply, you have 8 clinical features: neuropathy, ischemia, deformity, callus, swelling, skin breakdown, infection, and necrosis. We're just going to go through them quickly. So again, we talked about neuropathy. We have autonomic neuropathy, and how it affects the feet is you stop sweating. So patients with autonomic neuropathy stop sweating in their feet, which leads to fissures, which leads to a porthole for infection to enter, and eventually that leads to a major DFU and infection. Motor, which is bony changes. This is in Charcot and other things. So the bony changes develop in the feet, and patients end up not being able to fit proper shoes, and they end up with walking on the wrong parts of their foot, which lead to high plantar pressure, which then leads to ulceration. And of course sensory, which, like I said before, is 85% of your patients, right? So now we're looking at ischemia, so poor blood flow. That foot is salvageable? No. No. And that was a patient who came in and expected us to do miracles and save their feet. And this is where patients wait until their foot, and that's what I've said. I don't understand why you drive a car until it falls apart, and then it costs you an absolute fortune to fix, and it never quite drives the same after which. Where if you regularly service your feet and look after your feet, they don't let you down. And there's the macrovascular, which is the hosepipe theory, and microvascular disease, which results in the small vessels and the structural damage of the basement of the membranes of the capillaries. Both are equally devastating. Right, so now deformity. So deformity leads to bony prominences, as in motor neuropathy. Results in ulceration. Common deformities include claw toes, hallux valgus, hammer toes, the Charcot foot. Please differentiate between a Charcot and a cellulitis, otherwise you send your patient on the way to amputation. And related to previous trauma and surgery. This is a doctor's foot who was an ophthalmologist who specialized in retinopathy. But he thought his feet weren't important. He ended up going through the chopping board effect, lost the 5th, lost the 4th, lost the 3rd, ended up ulcerating under the first met head, eventually lost the foot, ended up with a Symes operation, ended up in a BKA, eventually he died 2 years later. And he was a doctor, so you would think doctors understand this complication more, but we as medics are the worst people to looking after ourselves. So, callus formation, right? Hyperkeratosis develops on areas of high pressure because of motor neuropathy. This leads to ulceration, and it's usually in the presence of neuropathy. Remember, if there's callus on a foot, this is a neuropathic foot, because callus will only form where there's a good supply of blood. If you have no blood, flow there, you cannot end up with callus. And 60% of your patients, if you remove and debride that callus, and we'll show you during the practical session, have a lower risk of developing a DFU. Okay? Next, please. Edema and swelling, right? So major factors predisposed to ulceration. Obviously, if you've got edema, you can't fit inside your regularly fitting shoes, okay? It impedes healing of established ulcers. Why? Because there's edema there. Bilateral edema is often secondary to cardiac failure, renal impairment, and venal insufficiency. When you talk about unilateral edema, this is usually associated with a local pathology in the foot or leg. The causes to this are obviously infection, Charcot, which is a big problem in diabetes, particularly in the rural settings, and Dr. Joy and I will have a conversation about that later. Trauma or fractures, and DVT. Okay, next please. This is much easier, thank you, because my thumb's getting sore. Right, okay, so skin breakdown. Remember, skin breakdown, classic signs of tissue breakdown is a foot ulcer. Fissures, blisters, some lesions will obviously, however, make their presence known by discharge, color changes, pain, swelling, and infection. And remember, most of your patients, the neuropathic, they can't feel, so they don't actually notice until it's too late. And the way for this is skin breakdown. Now, if you look at that foot, that is skin breakdown. Now, what's happening underneath that is a lot of people say, what do we do? Do we de-roof a blister? Do we leave it there? Do we allow the patient to go home on antibiotics? If you don't open the door on that foot and clean out what's inside there, you're sending your patient away for an amputation. Okay, so you must always de-roof a blister, and you must always debride it. You must always clean inside the room. There's no point in cleaning the front door. Okay, so skin breakdown provides a porthole for infection to enter. Diabetic foot infections, often diagnosed late. Infections in diabetic can be life-threatening and limb-threatening, and also must be treated very aggressively. Infections are usually polymicrobial. The most common are Staph, Proteus, and Pseudomonas, and anaerobes. There are two categories for this. There's cellulitis, which you must differentiate between cellulitic foot and Charcot. If you don't, you will end up leading the patient to an amputation. Soft tissue infections often involve deeper tissue and fascia and structures of that. So those are just as simple. And remember, deep soft tissue infections, debridement can be life-saving. It's the gold standard of treating diabetic foot complications, debridement. And in cellulitis, surgical debridement is not required. Necrosis, what would you do with that? Would you take that off? Would you leave it on there? Well, obviously there's a locked door there. That has to come off, but you've got to be very careful because there's no callus present there. So what can happen is if you start debriding that, you may lead a porthole for infection, and then you're opening up a whole can of worms. So King's classification of stages of the diabetic foot. Stage 1, normal. These are low risk, right? So your URI foot. Risk 2 is a moderate risk and has developed 1 or 2 risk factors, such as PAD or neuropathy. Risk 3 is ulceration. There is now skin breakdown and ulcer development. This is high risk. Now, these 3 can be treated as an outpatient setting. The next 3, which is 4 to 6, better to treat inpatient because you need an entire team approach. No one person can treat the diabetic foot. So you're dealing with cellulitis. The ulcer has developed a deep infection, and these are high risk. As with number 5, which is necrotic, and you ended up with infection, osteomyelitis. You know, people often ask me, how do you know if there's bone infection? Well, if you can probe to bone, you can damn well bet your bottom dollar that the patient is at risk of osteomyelitis. You don't need radiology. Just if you can hit the bone, you know that they're at serious risk and they have osteomyelitis. Major amputation, like those pictures there, and they need a BKA or an AKA to save their life. Examination, we'll show you in a practical session, examination, and people often ask us, and they ask myself and Richard as the podiatrist, how many times and where do we need to test? It does not matter, really. You know, nice guidelines, I don't know, what are they now? They're what, 8 or 4? It really doesn't matter. Some people say 16. You're not going to test the person 16 times. You'll be falling asleep, so will your patient before you finish. So these are things that you need to work. So those are generally. We don't test on the heels because they have callus. Okay? Vascular assessments, and this is what Richard is going to show you later. I will do the examination, and then Richard will show you how to do an ABI examination. And it's an ankle brachial index. It's a systolic blood pressure comparison between the arm and the ankle. It's a fast, effective tool for screening for PVD. And basically what happens is you take the higher of the two arm pressures, ankle pressures, and you divide it by the higher of the two arm pressures. And if you notice, it should always cancel itself out. Because if your blood flow is in your neck, you should have the same amount of blood flow in your feet, yes? But the problem is, because the feet are the furthest thing away from the heart, the first thing the body discards when it comes under strife is the feet. Discards the outer core, protects the inner core. So remember, generally normal is 9 or above. 8 to 9 is mild disease. 5 to 8, now this is where your referral pathways are very important. This is where you need to start referring to the vascular clinics if you have one. Now if you don't, this is what you need to do, but this needs a team approach when they get to moderate disease. Moderate to severe disease is 3 to 5, and anything below that is critical limb ischemia. Those are the pulse traces on the right, and basically you want triphasic pulse trace. If it's biphasic, you've got a little bit of blood flow but not enough, and then of course you've got monophasic. Treatment aspects, thank you, Doc. I have 5 minutes, so I'll rush through this quickly. Microbiological control. How many of you in here, and how many people, when you get a patient living with diabetes with a diabetic foot ulcer, has had every single antibiotic under the sun to manage a chronic ulcer? They have gone through everything, they are resistant to everything, so you need to basically possibly do a culture. And someone asked me once, when do you do a culture? And someone said, oh, you do it when the wound's dirty. No, because then you end up with a bacterial soup. You clean the wound first, and then you take it from as deep as possible in the center of the ulcer, and you make sure, and then you get to see what they require going forward. Metabolic control, this is where the endos are very, very important. How are we going to manage a diabetic foot if the top half is not managed? We need to manage the top half as well. So this is why we need to work in MDTs. Because if we don't, we'll end up leading the patient to an amputation. Mechanical control, 60% of your DFUs will heal with offloading, simple offloading, footwear. You know, this is the kind of thing. Make sure you advise patient on how to buy shoes properly, and make sure you advise them to buy shoes and thing. You know, I've always said women have 25 pairs of shoes. My wife has about 50 or 60. I have 4, and I'm the podiatrist. You know, and generally men's shoes are betterly designed. You know why? Because men buy shoes for comfort and support. Women buy shoes because they look nice with that dress that they've never worn for the last 6 months. Yeah, so again, generally women's shoes aren't designed as well as men's shoes. I've looked into this quite a bit. And educational control, we need to make the patient's relatives and caregivers own their condition, so that we can make sure that, that they are properly educated at that level so that they don't develop serious complications. And of course, vascular control. It doesn't matter what you do to a DFU. If there's no blood flow, it's like if you don't put petrol in a car, it ain't going anywhere. Okay? Principles for wound management. This is very simple. Assessment, evaluation, re-evaluation, and respond direct treatments. Definition of insanity, doing the same thing every single week, putting the same amount of topical on that wound and expecting a different result, and it's getting worse. Change it. Is your tissue viable? If the tissue is not viable, take it off. It's not meant to be there, take it off. What is the infection status of your patients? Is there moisture balance? You cannot heal a wound if you just send them home and stick some gauze on the top of it. And is there epithelial growth? And if the wound is changing, then you're probably doing the right thing. But if it's not changing for the better, then you need to change something within what you're doing. And you need to maintain the tissue repair process. This is what Isaac Maruka and I used to say for a long time when we were working at K&H. And we were constantly going is looking at the ulcer, seeing the difference, looking to see if it's improved. You have to see, if you see it going backwards, you change something. The at-risk foot, history, you must take a history, prior amputation. This puts the patient at very high risk. Prior foot ulceration, peripheral arterial disease. You need to check these things. Examine the foot for neuropathies, okay? PAD, check the pulses, the dorsalis pedis, the posterior tibialis. Next slide, please. So check for capillary filling. Check to see if that's filled in properly. Make sure you do an ABI, you know? So these are things that you need to look at. Other risks, inadequate patient education, inadequate patient motivation. Most of your patients with the DFU will be in depressed, anxiety, anger, and like Richard said, you know, if they have a severe diabetic foot complication, you can imagine that also up here is not really working very well either. Because if they have complications down there, it's probably up there too. So patients will forget, they won't treat, they won't deal with their feet. Physical disability, 2% of patients have retinopathy. They can't see their feet, they can't deal with it. Obesity as well, 2% can't reach their feet, can't even touch their feet. And also age matters, over 65, most people will have some form of neuropathy. And also limited to access to podiatry services, although we are improving that now in the country. Okay, we'll talk about categories and risk stratification, so I won't go into much detail on that, and we'll talk about that later in the session. But offloading, 60% of your planters, and my time's up, but just to say that 60% of your plantar ulcers will heal with corrective offloading. You know, simple stuff. And you remember motor neuropathies, the Charcot foot. Footwear is very important. Make sure it's lace-ups. Make sure you buy your shoes in the afternoon. Make sure they don't have a 6-inch heel. Make sure they don't look like you could stab someone with them when you walk. You know, these kind of things. Look at your feet today. Have a look and just think, if the shoe bites you, you can imagine what it's going to do to your diabetic patient. What we fail to do, we fail as clinicians to remove our patients' socks and shoes. We don't discuss the patient's habits with them, what they do, their lifestyle. And we need to ensure we make their lifestyle healthy without increasing the cost or changing it entirely. And just to quickly say, this is my last slide, the aim of managing the diabetic foot problems is to always keep the patient at as low stage as possible. A foot ulcer is a sign of a systemic disease. You can next. Yeah, and the next one. Yeah, and the next one. Yeah, and the next one. Okay, so successful management needs the expertise of a multidisciplinary team. And this is what we try to do here, which should include the physician, the podiatrist, the nurse, the wound care nurse, tissue viability nurse specialist, the orthotist, they're very important in offloading correctively, the radiologist, and the surgeon. Someone once asked me what the role of a surgeon is when it comes to dealing with the diabetic foot, and someone else piped up and said, oh, to amputate. Really? That's a great statement, because it's not. It's to salvage the limb, isn't it? No one person can take control of the diabetic foot. So with any diabetic foot ulcer, you need to treat the whole patient, not the hole in the patient. And that's coined from Philips Pharmaceuticals. Thank you very much, guys. I'm glad you listened to me today.
Thank you very much, Dr. Fabian Collis. We are now going to have a hands-on workshop. I'd like to invite to stage Arp Kalsi, Richard Hanford, as well as Dr. Joy Kamau. Kindly. Do we have any questions so far, or can we reserve them for the end of the discussion? Okay, so how many of us are surgeons here? question? Kindly, Professor Gugi.
Thanks, Corinne, for a very beautiful lecture and highlighting very important fact. But I was wondering, and perhaps the panel would be able to educate us on the use of chemical debridement, the drugs. There are so many drugs that the farmer is bringing to the market, saying this one removes red tissue, or wood healing ulcer with this one. And then there is the issue of granulation tissue. When you reach granulation tissue, there are pharmacotherapeutic agents that you would prefer or are preferable, because again there is a host of them, very expensive. And the dressing materials, I think you must be using some fancy dressing materials you'd like us to know about. Would you kindly comment on such?
Dr. Gugi, thank you very much for that question. Yes, I mean, dressing materials, there are a whole bunch of very expensive dressing material, anti-debriding agents, autolytic debriders that you can apply into wounds to soften the necrotic tissue. General rule of thumb, though, is, you know, they're very expensive. Most people can't afford them. So general Sharps debridement is the best. And you can do Sharps debridement at the bedside. What we did when we did a huge project with government and with DMI, and I think you were a part of it, Dr. Ngugi, we basically looked at bedside Sharps debridement, and we taught the nurses on how to do this so that they were able to do bedside debridement at the bedside, so that we stopped patients needing to go into expensive theater and having everything removed at such a level that then it became very difficult to heal the wound going forward. And generally, there are so many things in the market now, and for Center for Excellence, like we have a Center for Excellence at Lions, we do have access to these. But when you're in the rural settings and things like that, you don't really have access to these expensive topical applications. So we say debridement and general is the gold standard, and also normal saline. When it comes to autolytic debriders, you can use them to soften up. So what we tend to do is we use them at first to actually explain to the patients that this is the process we're going to take. When they come back sort of 3 or 4 days later, we now know that their tissue is quite soft, and we can then debride it using a Sharps debridement. Okay.
Thank you very much. I'd like to move on to the hands-on workshop. Can I have the PowerPoint displayed, please? And I'll have you know, Dr. Fabian Collis, it's because of these 6-inch heels that I can be seen beyond the podium. Otherwise, I'd have to stand in front. So they have uses as well. Okay, like I was asking, how many of you are surgeons here? Wound care nurses? Okay, I see a handful, a footful. And the rest of us are physicians, right? So we are the primary point at which the patient comes and says, I have diabetes, I'd like to be treated for the diabetes. And remember, it's not just the diabetes that we need to treat them for. It's not just the blood sugars going up and down. It's screening for the complications. It is management of their mental health, something that we negate a lot of the times. And just like my colleagues mentioned earlier, we do not remove footwear and we do not remove socks. Something that I learned from one of the elders in our society is, whenever you have a person living with diabetes touch their feet, it was supposed to be metaphorical and romantic, but then we did touch their feet and they were smelly. But we also saw a lot of changes that reflected the other complications that happen in the body. We saw nails that reflected uremia and that reflected that this person may be having concurrent CKD. This is a clinical examination. This is not biochemical. This is your first contact with the patient or the PWD or the person living with diabetes in your clinic. This is the first time this person's come to you. So a foot examination can reveal a lot. Decreased or absent pulses can mean that this person is also living with cardiovascular disease concomitantly, also at risk of having a stroke. So let's all keep that in mind, and that's why it was important for us to focus on diabetes-related foot care in a diabetes symposium. Having said that, we have a standard 3-minute foot examination that all of us must learn and must implement in our day-to-day practice. It doesn't mean that every time a patient comes to you or a PWD comes to you, you have to go through or take a look at their feet every single time. There are times when you have to look at it annually. There are people in whom you can look at it biannually. There are those in whom you have to look every 3 months, and we will go through those. So I will play a role as a physician, and I'm going to say that these are the questions you ask. It's a really quick 1-minute foot exam for the history taking. Does this person have a history of previous foot ulcer? Does this person have history of leg amputation or surgery? Make a note of it. It puts them at a high risk category. Does this patient have history of angioplasty, either in the leg or even in a cardiac stent? Does this person have an active current foot wound? A lot of the times they're going to tell you, no, I don't have a foot wound, but then they're going to reveal the socks, and there's a nice heel fissure sitting right there looking at you, and it's thick, like the callosity that Dr. Collis showed you on the slides, and you're going to debride it and you're going to see that's actually a wound. So they may not know it, but you've got to look for it. History of diabetes, yes. What is the current patient's control and what are the measures that they're taking? Does the patient have history of neuropathy? Is there burning or tingling in the legs and the feet, or in the feet? Positive sensory symptoms, negative sensory symptoms. And is there any pain with the foot when there's activity? For example, all red angry feet need not be cellulitis. It can be a Charcot foot. You can treat a red angry foot with antibiotics and it will not resolve. Next comes the diagnosis of Charcot foot and even DVTs, right? We tend to go towards DVT because it's a medical thing, but Charcot is a very important thing to rule out in persons living with diabetes. Changes in skin color or new skin lesions. Loss of extremity sensation. Does this person have a regular podiatry care? How many of you have access to podiatry care? Just a handful of us, right? Can we change that? Should we change that? I think it's extremely necessary, and we can only do that through our network, right? I'd like to now hand over to Fabian. Fabian, you can pick that up and talk about the...
Practical. Sorry, this neuropathic as well. Practical. So what we're going to do today is we're going to do two things. We are going to start with a simple examination of the foot. I would like to pick on someone, please. Who would like to be picked on? And everyone goes, no, 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 don't come over here. Okay. So who would like to, who can we use? I think...
Should you volunteer?
Yeah.
No, 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 you don't want to volunteer? Betty? Betty? Hi. Come, please. I'm picking on Betty because she's wearing the best shoes. They're the nicest looking shoes, but they're also seriously unfunctional. So, yeah, all for the wrong reasons. Lovely, beautiful, make the calf look lovely, but not very functional. Right, so we can start off. Always make sure that when you observe your patients, make sure you check how they walk, because as you know, with motor changes or motor neuropathy, they may walk differently. Also, check the footwear. Betty, can you take off your beautiful shoes, please? So, that's a good shoe for a diabetic, yeah? It's great. It's got a 4.5-inch heel. She's narrowed down her surface area of her foot to her toes, which takes all her weight. It doesn't bend at all, and functionally for a diabetic that is leading to a major ulceration, and she could probably stab someone with that. So I'm just going to put it there so that you all can see that beautiful shoe. Okay, Betty, will you put your foot up here? So when we're examining a foot, simple things, okay? So I hope you can all see that. Can you see that? Yeah, is everyone there? Okay, so when we're looking at a foot, what we're looking for, we need to ask the questions. We need to look at the skin condition. Okay, so you can examine a foot very quickly. How many pulses are there in the feet? How many? 3. So you're looking for all 3 pulses. If you can feel 2 out of 3 pulses, the patient has no risk of developing poor blood flow or ischemia. So you're looking for the dorsalis pedis, which is on the top. You're looking for the posterior tibialis pulse, which is just behind the malleoli, okay, which is there. And Betty's heart rate's going a little bit because I'm showing her feet. And you look for the DPP, okay? So that is a V shape between the big toe and the second toe. If you run your fingers down, you can actually feel. So remember, you have to detect 2 out of the 3, and then you don't need to. But if you can't do that, then you need to use a Doppler, which Richard will show you in a minute. Basically, look between the toes, okay? Make sure that there's no fungal infections. Make sure there's no interdigital maceration. Make sure you look at the nails. Make sure they are cut straight across. You know, a lot of people paint their nails. If you're diabetic, you've got to be careful. You know, painting the nails, I always say that painting the nails was used in the 1900s for women who were prostitutes who needed to hide the disgusting fungal infection on their nails. So anyone who wore nail polish back in the day in the UK were interesting ladies of the night. So check between the toes, feel the temperature of the skin, because remember, in a hot foot you suspect an infection, either cellulitis or or Charcot. So check the temperature, use the back of your hand, okay? Make sure you check for warmth or anything else. Look for the footwear, and in this case it's not great. So if you look for good fit, no. Look for good shape, no. Look for Velcro or laces, no. So that foot is absolutely not. Look for deformities of the feet. So look for any deformities in the feet, because remember, in a motor neuropathic foot, high arches. Betty's got quite a high arch, and she actually has quite a nice foot. I don't have a fetish or anything. Right? Callus tissues, look for any calluses on the heels. Look for any calluses on the metatarsal heads, because you'll find in your diabetic patients they've developed a lot of calluses under the metatarsals. These need to be removed if there is present there. Make sure you look for any ulceration, because that puts the patient at a high risk. And of course, if the patient has an amputation, you're dealing with an extremely high-risk patient. Check the pulses, as we've done recently. And then what we need to do is using a simple monofilament tester, and we have some monofilaments. So if you guys do well in the post and pre-test, we'll give you some monofilaments, a few who win the competition. So just a simple 10-gram monofilament. And what you're doing is you ask the patient to close their eyes, and all you do is just tell me if you feel this, Betty. And where am I touching? Yes, thank you. And then you move on to the 5th. Yeah, and you can move on to, do you feel that? The 3rd. Then we move on to the first met head. The 2nd and 3rd met heads, and the 5th met head. And just ask the patient for their responses. If their responses are poor, you know they're neuropathic. Okay, so that's it. And then what you need to do is you need to make sure that the skin's intact. What you need to also do is you need to make your patient walk to see if they have any biomechanical changes in their feet, if they are pronating or supronating. So it's a very simple examination. Just have a look at the foot. Make sure you advise your patients accordingly. Make sure that they don't put their feet near open fires. They make sure that they wear the right shoes. They do the right things. They don't put Vaseline on the feet, because Vaseline just locks in moisture, and also it collects everything. So those of you who use Vaseline and patients living with diabetes, don't. Okay, so that's it. Thank you very much, Betty. I appreciate that. So I'm now going to hand over. So that's a simple examination. You know, you can also test for sensation loss using a 28 megahertz tuning fork. Just something you can measure a piano. You can check on keys on a piano. Makes a noise, and you apply it to the area for vibration and check, because this is for temperature. So patients often don't have any, they can't feel any temperature. So they can put their feet near an open fire and burn their feet. And before they've realized, they've got serious complications. And you can do a hot and cold filament test as well. So this is hot and cold. You use a cold and a warm area, and you just ask the patient to differentiate between the two. So those are simple, that's a simple examination. It's very easy, but always make sure your patients take their shoes off and you look at their foot. Because you will send that patient back, they will end up coming back 2 weeks later with a DFU or a diabetic foot complication, and now you're dealing with a very complex issue. Okay, so that's examination in a nutshell, simple examination. Make sure you do that. And it doesn't take a physician to do it, anybody can do it. Okay, thank you guys. So I'm going to hand over to Richard now, because now Richard, so Betty, you can stay there, because I think Richard is going to go through vascular assessment, and I'm just going to go and get you the Doppler, Richard.
Thank you. So now we're going to use a Doppler ultrasound scanner, which some of you may have used in the past, because we can now actually listen to the blood flow. So palpating a pulse is one thing, and it's really useful, particularly if you haven't got a Doppler. At the end of the day, if a patient's got a pulse that you can palpate, they have got some viability. If you can't, then clearly there are other issues going off. It might just be edema, and there's a decent arterial blood flow underneath that edema, but if they haven't and you can't palpate it, then clearly it's not a very good blood supply at that time. So we use a Doppler ultrasound to be able to listen better to the pulse. So how many people have used a Doppler ultrasound on feet before? You have a show of hands? It's quite new to most of you then? Okay. Okay, so first of all, in this case, we're going to just quickly find Betty's dorsalis pedis, because we're going to listen to that. Thank you. Okay. So we use some ultrasound gel because we need to get a transmission. So yes, Betty's definitely stressed to be on stage, judging by the heart rate. However, significantly what we can hear here are basically two whooshes. So you're hearing the viability. You're hearing the viability of the blood vessel. We're hearing the expansion and contraction of the artery, which means we don't have too many plaques, which we wouldn't expect on Betty at her age. So this is a biphasic pulse, which is really what we want to hear as a minimum. Occasionally in a teenager you will hear triphasic, where you actually hear the rebound of the blood vessel. As a lot of our patients get older, they'll have arteriosclerotic plaques and effectively hardening of the arteries. Then this clearly is, I'm a man, I can't do two things at once. So there we go. So we'll have a monophasic pulse and more of a slush or a whoosh. So that still means that there's blood getting there, but it's not going to be enough if they already have comorbidities or other injuries to the foot. Okay. So as far as checking for an ABPI, so what we're going to do now is we're going to use the Doppler probe to listen while we inflate the cuff. And we'll listen until the point where the blood, we can't hear the blood flow anymore, which means we've effectively shut down that blood vessel briefly. At that point we measure the milligrams of mercury on the millimeters of mercury on the dial, and that will give us our reading for the ankle. So we would usually do both pulses, but for demonstration we'll just do the one. Okay. So now got about 120. That's 100. You can hear it coming back now. So one more time. Just check it's actually. So we're basically about 100 there, as you could hear it where it disappeared. So that's 100. So we'll just do the one pulse on Betty for now, and then Dr. Shilpa is going to do the brachial, which is basically the same thing. So I think in terms of process, so while they're just getting that sorted, everybody on the table got the ABPI crib sheet. I think there's a copy. So this is the easiest way. It's basically just fill in the numbers and gives you the maths. So, as I say, as you can see, you would normally be checking more than just the one pulse in terms of the foot and left and right, etc. But we're really just trying to illustrate the process at the moment. So, because we'll do left and right sides, so in this case we're only going to do the left. And once we have these, we'll have the basic maths to be able to work out that ratio. So, while we do that, just a note about ankle brachial. We've put on the crib sheet that in terms of the ratio and the result at the end. So there's always local guidelines, and there's some debate always about which point to refer. So that's usually local, and that's in conjunction with your vascular team if you have access and that's what you're doing. So I'll just move this over now.
That is a strong pulse. Betty's stressed.
There's about 90. Okay, so if you want to fill that in, just to illustrate the basic maths. So yeah, as I say, there's some debate often locally on at which point you refer, and that's usually down to the local team. There's also been a lot of research on ABPI, and there's some debate often about its usefulness. It is validated, it is really useful. There are times when it's not. So if you have a patient who has some severe arteriosclerosis, that's going to skew your figures because it's going to change effectively the point at which you're going to be able to reduce that circulation. So sometimes you have to be a little bit careful with your patients, but it's a good screening tool, and it's relatively easy to do. So, sorry, has anybody worked it out yet? We're going to be, I mean, we know it's going to be good because effectively the ankle was higher than the brachial.
100 divided by 90, that's 1.11.
So 1.111111.
Is that normal?
No, so Betty's okay. Yeah. Huh? So we're going to talk later about one of the assessment tools which is often used, and the ABPI or ABPI forms part of that assessment because you'll score it. So we'll talk about that later. Okay.
Arv, do you have any questions in regards to if you are a carer? Are there any questions that come to your mind in regards to diabetes foot care?
Thank you, Dr. Shilpa. So quite a few now that I have Fabian and Richard on the stage here. Fabian, you almost gave me a mini heart attack when I saw the costs of escalating diabetes complications. So caring for somebody living with diabetes, what are the measures I can take at the home environment to reduce the risks of them developing complications of diabetes?
Thank you. So this is where education comes in. It's very important that we look footwear, as we've discussed, and as Betty has the best shoes in the world, and we need to make sure that our diabetic patients or diabetic patients living with diabetes do not have shoes like that, because that will lead to ulceration. We need to also make sure that they clean their feet regularly and they look at their feet. For example, you know, a lot of patients live alone, yeah, and they don't. So you need to ask them, and some people can't get down to their feet, so they can't see. A mirror on the floor, right? So a simple mirror on the floor basically can tell, and you just put your foot over. At least now you can examine the bottom of your foot. Because if you're neuropathic, you can't tell if you're damaging the bottom of your foot. So just stand and put your foot over a mirror, and you'll be able to tell if you've got any complications. Also, make sure patients cut their toenails straight across. You know, make sure, and some people can't get down to their feet, so make sure you teach the caregiver to cut their nails straight across. Don't put your feet near open fires or hot water bottles, because if they end up with a burn, and because there's a delayed response because of neuropathy, they end up burning their feet, and this can lead to a flood of complications as well. Generally, make sure if they've got edema and everything, and remember, a lot of your patients will, because of motor neuropathy, won't walk properly. So they end up walking like a duck or like a penguin, and they don't heel to toe, which means they don't activate their calf pump properly. You know, if you push water off a building, where does it go? It goes down. Why? Because of gravity. How does it come back up? It needs an adequate working pump. Now, as cardiologists sometimes refer to your calf as your second heart, because that's the main pump that pushes blood back to the heart. Now, if you're not walking properly, you're not activating that calf pump properly, which means then you're much more prone to varicose insufficiency as well. So these are simple things you need to look at. Just examine your patients in clean water, wash their feet, check their feet every day, make sure you don't, you avoid temperature and heat, and just generally, just make your patients aware that there are diabetic foot complications and they need to check their feet. You know, the problem with feet is out of sight, out of mind. You stick your shoes on in the morning, you go to work, and that's it. You don't bother taking them off again. And if you're a patient living with diabetes, you're at serious risk of developing complications. So I'm going to hand over to Richard, because he might add something to that.
Yeah, just a simple take-home message would be for Arv as a carer, or to the patient themselves, is this is all quite complicated for a patient in terms of talking to them about different lesions, what they should be looking for, what they shouldn't be looking for, and they get confused and they're less likely to undertake any of the advice that we give them. So a real take-home message for a carer or a patient is basically to look at their feet every day, which a lot don't. So it's very much like their teeth. If you look at your feet once a day and you get used to what's normal, because they will be elderly, they may have other comorbidities, so they won't look like the classic picture of a healthy foot. So if they get used to looking at what their foot is like when it's normal, and that can be different times of the year, temperature, etc. Yes, they'll cut their foot, yes, they'll get a blister, and it will heal. They get to know how long those things take to heal. So they now have a level of normal, and it might take a couple of months for them to do this. The advice to them at that point is if you check your feet every day and you see something that's not normal, You don't have to know what it is. You don't need a list of 250 things that it might be this and it might be that, and they don't understand it anyway. If it's not normal, they're not happy about it, they seek help. It's as simple as that. It's not confusing, it's not frightening. They get used to seeing it, a bit like not looking at your bank statement. If you don't look at your bank statement, you probably are worried because there's something wrong. That should already be alarm bells. So if they do that, when they come to us, you as clinicians present at clinics, it also means nothing's more than 24 or 48 hours old. And when we ask them those questions like, how long have you had it? And we get those vague answers of a while or I can't remember. They don't have that. They can say, I've had it 3 days, 2 days, 1 day, a week ago it wasn't there, it's got worse. So you've already got that information that you need as a clinician to start to make some decisions for them. So check your feet every day, get to know what's normal. If it's not normal, present.
I have another question. Is there a link for somebody who's been diagnosed with gestational diabetes? Is there a link to diabetes foot complications in relation to that?
Not directly. But what's interesting is when you have gestational diabetes, you're basically, the baby is generally heavier. So what happens is your weight increases. And what happens is, we know, in podiatry terms, we know it as the pregnant foot syndrome. So basically what happens is you have 4 arches in the feet and they naturally drop to adapt to the new weight. You know, when people who are just generally overweight, they gain weight over a long period of time. But people who develop diabetes and gestational diabetes, they gain weight very quickly over a very short period of time and their feet naturally drop, or the arches naturally drop, which changes their biomechanics, which means they start to pronate or supinate, they don't walk properly, which then leads to serious foot irritation. So indirectly, yes. Directly, not so much, no.
Another question I have is, where you have people living with diabetes and they have pets, why should the pets not lick the feet?
Well, apart from the obvious, yeah, so the problem is this occurs often usually in the elderly who are living alone and their pet is their only member of family or best friend, and they get very close to that pet and they basically lose a little bit of perspective on basic hygiene and things. So yeah, the worst thing to find is any form of a wound, whether it's a diabetic foot ulcer or even a post-op wound, which I've had, where you can't work out why they've got an infection or why it won't clear up, and then you pull the dog hair out of it. So it's really unhelpful. So it is worth educating your patients that if they do have pets, and so obviously this can be in a chamber as well as in the home, that actually basic hygiene and just remembering that something that's very normal to them actually might have crossed a line from our point of view, from a clinical point of view, that is really unhelpful.
Okay, and my final question in relation to moisturizing the foot. You mentioned not to use Vaseline. I used to use the Astral cream for my mother to moisturize her feet. So one, why is it important to moisturize the feet, and what do you recommend to use?
So as we know with moisturizers, you know, with neuropathies, if you are someone who's suffering from autonomic neuropathy, your skin dries. You don't have enough moisture in your feet. Because they're, again, the furthest thing away from the heart, the first thing that the body will discard is your feet. So they will dry, they will become anhydrotic, they will start to crack, and leaving a porthole for infection to enter. So general good emollient creams are very good. So Arv, you need to suggest that emollient creams, again, we don't use Vaseline because Vaseline basically blocks the pores, and it basically, have you ever put Vaseline on your feet and then walk across the garden? How many things do you collect? Everything, right? So don't do it, don't give it to your patients, because you'll collect everything, you'll end up with the sort of a greasy foot, then you've got to go to bed, and then you think, and then your spouse or your partner won't be very happy with you either. So I think generally good moisturizers and regular moisture. So daily moisturizing your feet, because you need to protect them. You need to protect the integrity of the skin. So moisturizers are very important. You don't use things with acids in or kali things, because what will happen is you just might burn the feet, particularly if the feet are vulnerable. So good emollients, good moisturizers, just a standard one, not too perfumed, and just use that. And you can get them from any supermarket or shop. Okay, thanks.
Yeah, so urea is a hydrator, so in really simple terms, it encourages the skin cells to pick up moisture and drag it in. So most of them will have a percentage between 10 and occasionally 30, but usually this 10 to 20%. It seems as a product, most of the foot creams have 10, and what are then described as heel balms for cracked heels have 20. A final thing with emollients is patients don't like them. I mean, none of us like them really. We don't even like sun cream when we go out in the sun. It's greasy and it sticks to your clothes, and you have a shower and then you go and put a load of cream on, you feel like you need another shower. So one of the, to get patients to do this a little bit more is they also have a tendency to feel you've just got to do this big dump of cream in one go and cover themselves all greasy and horrible, hence they don't want to do it. So a little and often is better. So a small film but more often, and that's less greasy and they're more likely to do it because it feels better. And really, of course, you're also mimicking normal natural sebum production. So it's better than I put cream on once a week and I put half a tub on and feel awful, so I only want to do it once a week. A little and often is much better. So that's a better way of negotiating with your patient to get something rather than nothing.
We had a discussion earlier. May I have the slides up, please? We had a discussion earlier, and you were talking to me about how we need to understand who's high risk and low risk, and you read up about this. You want to elaborate?
Sure. So what you can see on the slides is the International Working Group on the Diabetic Foot Guidelines on the risk stratification. So you can see we've got the risk stratification of 0 down to 3, and if you look at 0 is very low, 1 is low, 2 is moderate, and 3 is high. So just bear this slide in mind as we move to the next session of the workshop. For those of you who don't know what loss stands for, it's no loss of protective sensation and no peripheral artery disease. So you can see, rather than going through it in too much detail, it's projected on there, and due to the time elements, I'm going to move forward to the next part of the workshop.
Okay, so we are going to continue as a panel discussion. Running through very quickly once again, I did mention that very low risk feet require annually once review. This means that if a PWD, a person living with diabetes, has no loss of protective sensation and no peripheral arterial disease, that means they feel they want to live very well and you can take their pulses at minimum. This person requires an active annual review. So like I said, unless there's an issue, if it's a newly detected person with diabetes or a person with a long-time diabetes but good control, does not have loss, does not have EAD, an annual review is adequate. A low-risk foot is somebody who has developed the loss of protective sensation, that's absence or reduced monopolar testing, or a reduced tuning fork, the sensation, the vibration sensation, or a person who has reduced output, or if you have an ADI available to you, and if the ADI is less than 0.9, this is a low-risk foot. And you need to keep this person in your clinic, visit this person in your clinic every 6 to 12 months minimum. A patient may complain of loss of sensation, take care of toenails, if there's an ingrown nail, you must need to tell the podiatrist to take a look at it, right? And these people also may have non-ulcerative manifestations of diabetic foot, like dry cracked skin and a sore that may not be as such. This is Richard's expertise, non-ulcerative diabetes management.
Hi. So these are just two examples of common problems that can cause break in the skin and loss of skin integrity. And they're really simple. They're not the complicated ones. They're not trauma, nothing's happened. These just will happen, in a sense, they're normal conditions that happen at normal people, in a healthy healthy people, but if they happen to somebody living with diabetes, they start to become a risk factor. So generically athlete's foot, so that can just in itself be maceration, so that's that wet, horrible, spongy skin. It can be plus or minus a tinea infection, so 90% of these are Trichophyton rubrum, so which is a dermatophyte, and really it's in the first instance it's hygiene. This is people not drying between their toes, particularly the fifth toe that burrows underneath. Teenagers are the worst, I'm sure we've all had it. It's easy to dry the rest of your body with a big bath towel, and then you use a wet bath towel, tap the feet, and you've dried them. So unless that moisture is removed, you are then going to find that you're going to get maceration. It itches, ultimately it can fissure. Excuse me. So one of the problems with or without a fungal infection is you can get a bacterial infection, which is that lovely green one in there. It's not a bad slide, it is that green. So this is a bacteria living on that nice spongy medium that you've created. I've seen it in young footballers who are fit and healthy. They'll actually get an anaerobe on there and it'll burrow down, and you actually maybe get a 5-6 millimeter cavity going in between the toes down to the head in a sort of a healthy 17-year-old lad. They're anaerobic, so they have to go on metronidazole, which for that healthy 17-year-old footballer means they can't drink for a week, so they're absolutely devastated. But this is down to poor hygiene. So from our point of view, most of them are treated just by good hygiene again, drying, and you can use surgical spirit as long as the skin's not broken, because that will dry it out and reduce the sweating as well. Heel fissures. So our heel is basically a sponge. It's a fat pad with a piece of skin around it, and it's supposed to deform on heel strike. So if you have an unsupported heel, you will start to get callus formation perfectly naturally. However, if that's not managed, or it's constantly being overstressed, this is mechanical stress. And you see people walking on flip-flops down the side of the road, half off the flip-flop, half on. They're going to have a very thick heel, or heel callus. So that heel cup now has to deform because you're walking on it, but it's got a hard layer around it. So what's going to happen now is that hard skin is going to split. You've now got a fissure, which by the time it gets to the dermis in a heel is going to be like a paper cut. That is now a risk factor again. It's painful for somebody without diabetes or any risk factors. It's now a risk factor for a diabetic patient. So good heel cup, hence good shoes, an emollient, possible debridement if they've got access to that, and that can be easily managed basically with long-term with advice.
You always specify a way that you use the constants.
Yeah. All of you who love pedicures and rubbing the hard skin off your heels with pedicures when it's nice and wet and the skin's nice and soft, don't do that. The reason is because you need some protectant. And also, when you start rubbing skin that's soft and wet, when the pedicure soaks your feet for like 20 minutes before they then take a cheese grater to it, they're going to seriously damage your skin because it ends up with hyperkeratosis. And that's why people who do that. So if you're going to take hard skin off and have the thing, you need to manage it. You need to use like a simple file before you then wash your feet and then use a moisturizer. So do it the opposite around. So all you people who like to go for medical pedicures, please make sure they reverse what they do. Okay? Thank you. Off a lovely smell. So if there's a smell, then you know they've probably got a fungal infection. So one of my professors used to say, just get your nose down there and have a good sniff. And if you smell that, then you know that there's possibly a fungal infection.
Please give the video.
Yeah.
Okay, this is to illustrate the mechanical stress, if you like, on a heel. So this water balloon is effectively our heel cup on a normal flip-flop where there's no support. We're in a Birkenstock next, which has a small lip, but it can still move around. So that's where you get that mechanical stress,
Yeah.
where you'll start to get callus formation, whereas the trainer with the proper heel cup on the right-hand side, that gives full mechanical support to the heel apparatus, so you're less likely to get that callus formation and therefore the fissures.
Yeah.
In combination with emollients, that will help a lot of your patients really simply and really cheaply with little intervention.
So we talked about very low risk, we talked about low risk. Now coming to moderate risk. Moderate risk is when a person living with diabetes or CWD develops LOX plus PAD. Persons living with LOX plus PAD do end up having motor neuropathy. The nerves, one of the functions of the nerves is to maintain the architectural structure of the foot. When the communication lines that are the nerves or the communication lines that maintain these, when the communication is down, the architecture forgets to remain the way it's supposed to. Our feet are designed to take pressure equally in specific areas. When there is no equal distribution is when we have pressure points as seen, as highlighted in the red underneath the feet, and this is where people living with diabetes develop ulcers in the foot. When you see calluses, you will have mostly seen calluses in your OPDs, if not wounds or ulcerations. If LOX and PAD is associated with a foot deformity, or the PAD is associated with a deformity, please review these patients every 3 to 6 months. These calluses need to be taken care of. The examination needs to be done often, and we should be able to deride as and when necessary. And if there's PAD, of course, please try to involve a vascular surgeon. At this point in time, I'd like to draw Dr. Joy Kamau, who works in the clinical side. When you see a person with a moderate risk, how easy is it to look in a vascular surgeon?
It's probably not easy at all. I think how many of you work in a public facility? Quite a significant number. How many of you have a vascular surgeon where you work? 1, 2, 3. What hospitals? Probably level 6 hospitals? Yeah? I'm seeing nodding heads. Okay, so I work in a level 5 hospital and previously worked again in Thika, which is a level 5. I'm speaking for Kiambu here. We don't have many vascular surgeons. So what we end up doing is if you examine the patient's feet and you find that they might have some missing pulses, and if you're lucky enough to have a Doppler, a handheld Doppler, or you send them for a Doppler scan and then it comes back iffy, so you have pulses that are not ideal, then you might want to send that patient to do a CT angio and see the vascular surgeon. Typically we'll reserve the request for CT angio to be made by the surgical team, because at that point they're making the decision of, do we need revascularization, or are we in a situation where we already need to do our can we do limb conserving treatment, or do we need to go on ahead and take the foot off, do an amputation. And in really limited resource settings, which I will talk about later, some of the considerations that you're having are, you have to think clinically. Can I feel those pulses? If I can feel those pulses, then I'll go, okay, it's not so bad, and then plan for those more invasive procedures, more advanced investigative procedures. But we don't have access to a vascular surgeon. So the times when I'll send a patient to a vascular surgeon is usually if I've spoken to the surgical team and we think there's a chance that this patient might need revascularization, or we are not entirely sure whether they need a CT angio to make the decision for whether or not we're going to need to do an amputation. Sorry for the long answer.
That's fine, that's what we need to know. Many of us still do not have access to vascular. So it's important to understand that we do still, I need to build referral networks amongst ourselves. Even if not, let's say it's possible within our institution. I think we need to start getting more referral networks with institutions that have access. And
Jenga, you here? Dr. Jenga? Oh, he's left. Oh, yes, please come up because I want to do something with you right now. So this is known as a Harris mat. Jacinta, will you come and do it for me, please? Thank you. So I've picked Dr. Jenga because he has a fat, flat foot. So I want to show you what happens when we, this is why footwear is so incredibly important, and this is why you should all look at your shoes, because it makes a huge difference to saving and preserving the foot. And this is why patients living with diabetes need to make sure that their foot is, patients will go back, they will be told that their footwear isn't, they'll come back 2 weeks later to you, to the clinic, with the same shoes that caused the same problem in the first place. And that is crazy. So, right, Jacinta, let's put it down. So, when you look at patient, you always look at a patient's walk. Now, I know Dr. Jenga won't kill me for saying this, but overpronation, walks like a duck, okay, has a flat foot, right, and doesn't, and when patients have who are living with diabetes have these kind of foot types, they are much more prone to developing ulceration on the medial border of their feet because they pronate, which also leads to knee pain when they get older and can lead to sort of hip discomfort as well, because biomechanically the tires aren't balanced properly. So let's take an impression. So I want to see you what happens. Dr. Jenga, I want you to just walk through this mat for me, please.
Disclaimer, if the orthopedic college is not found anywhere in the hall tomorrow, there are 2 suspects.
So let's go back to that previous fat and flat. No, so what happens is here is there's no structural support on the medial compartment of the thing, and Dr. Jenga has a flat feet, and I know he won't mind, and I'm sorry I'm picking on you, Doc, but that means that what happens is patients who have flat feet are more prone to developing ulceration than people who have good supporting arches. But remember, general rule of thumb, if you have a very high arch foot, you're more likely to get hip pain, and so because your shock absorbers are too tight, and if you have flat feet, it means that your shock absorbers aren't working properly, and you're more likely to get knee pain or shin splints or medial pain in your legs. And what it also does is when you're flat-footed, you tend to walk very much in an externally rotated position. Yes, Prof. Okay, so can I borrow someone with a knife? Okay, Jacinta? So let's do a high arch foot. So Richard, will you help me around here? So now we'll do someone with a high arch foot, and then we will. Have you got a high arch foot? So general rule of thumb is you need orthotic devices. So they're simple, and please guys come and have a look at what we have. Well, I've got some, I'm not selling these, but you can come and have a look to see what we give to diabetic patients. So I'm just gonna, Richard, I hope you don't have a flat foot either. Dr. Rosie said, why is there male biased? But just generally to show you, so you can see that is, well, what happened to your second toe, Richard? Nando Api. So as you can see, let me show you. So there is between a nice arch foot and a flat foot. Okay, so you can imagine that with your patient living with diabetes, if they have a foot like this, and a Harris mat, they're not expensive, they're about $100, and you can get them and you can use them, and they measure foot pressures. You know, if we look at the slide, there's loads of things. There's the podiographs, there's the computer-generated gait analysis, but this is just a simple Harris mat. And back in 2010 to 2014, when we were working with DMI and government, We actually we've sent a lot of these. So there, thank you, Dr. Thank you, Dr. Flo. So you can see she's also got a very nice foot there. So but she doesn't put her 5th digit down properly. So generally, we're just showing you different types of feet, okay? But that's what you need to look at when you look at your patients. Thank you very much, guys. Dr. Jenga, I'm sorry I insulted your foot.
May we have a slide? So what you see is a hazmat, right? That's something that is easily within the reach of any institution if we ask the maybe Dr. David can tell us where to get one at the end of the morning.
I think generally, I think, you can see by the picture on the top right, these are high points of pressure. So you can see that those points of pressure, please go back, are high risk areas. And these areas, and if you exacerbate that by wearing the wrong shoes, you now lead yourself to a DFU incredibly quickly. Highest points of pressure on the foot are generally the heel and the metatarsals, but the arch is there to protect the integrity of the foot and make sure that you walk properly. And you can see the offloaders there on the hallux is also very high. So this patient has a risk of developing ulcerations not only on the heel or on the met heads, but also on the hallux. Harris mats are regularly available. You can pick them up. They're fairly cheap. I mean, when we say fairly cheap, I know in certain centers, but they also last a very long time. That Harris mat I've had for 20 years, and it's still working. And if it can take all the pressure that everyone keeps walking on it, and it's still working, then it's great. So you can do that. The podiographs and things like that, and the podia steps, they're a lot more expensive. And if you have Center for Excellence, you can probably afford that. But again, the outcome's going to be the same. If you get pressure, you know where it is, then you can offload it correctively.
I think the pedograph would play a better role in setting in which research is happening, where you get numbers. So in many cases, the pedograph have numbers and they have pressures. So you can pick these up and use them for research rather than clinical evaluation. And of course, because we find that there are areas in moderate risk feet with high pressure areas, as we've seen in the previous slide, there are customized orthotics that may be equivalent or resistant to that question.
Yeah, I think generally these are just offloading, so you redistribute the weight evenly through the foot. So orthotics are there to protect the integrity of the foot, make sure that it's comfortable, and make sure you prevent. Prevention here is thing. You can treat a symptom, but if you don't treat the cause of why that symptom's happening, then you're not going to think. I've often said to people, you can take the car to the mechanic and have the tires balanced, but what causes the problem in the first place? The road. If you don't fix the road, then you're going to be taking the car back to the mechanic every 3 months. So best you get proper orthotics. Anything to add, Richard?
No, I suppose there's always the difference between a simple insole and an orthotic. So generally a simple insole will be foam or EVA base that will redistribute pressure. You can put some holes in it to offload areas, support the arch, etc. And then you go into a customized orthotics, which is what's on the screen, where you measure against the actual shape of the foot, and you're trying to then actively dictate what the foot does by putting postings on, so you're then changing foot function. But in the context of our patients that we're talking about today, at a high risk, the simple insole with the right additions, a hole in the right place, good materials, will make a massive difference to the outcome. They don't need the full customized orthotics, so don't be afraid. One of the things that, and in coming to Kenya, that I spoke to, I found out from Fabian very quickly is getting access to some of the more technical materials is difficult. So Fabian's always recommended buying the cheap yoga mats. That's a huge, large area and a very cheap, reasonably good quality sponge foam that you can use use with your patients and customize, and you get a lot of insoles out of a yoga mat. And actually, rather sadly, the next time you're in a supermarket or with the yoga mats, do squeeze them and see the different densities, because again, you can use that to your advantage based on either the weight of the patient or activity levels, or if you want more correction, if you like, you can use the different densities.
Thank you very much. Joy, I know that you have an interest in uploading as well. Do you want to add something very briefly in regards to this?
Not really. I just possibly could say that you might not always be able to get these orthotics that are what we call total contact orthotics, because it's made to match the shape of your foot, and there are different ways to do it. There's some in which they warm a gel and you step in it and then they get the insole out, the orthotic out. But in the worst of cases, what I simply tell my patients is, you know what, just look at the inside of your shoe, and if your insole is really thin, you're not helping yourself out. So it kind of depends on the type of shoe that you have to start with, and just a good insole can make a huge difference. I'm going to go later show you a couple of shoes that look good on the outside and probably aren't so great on the inside. Additionally, orthotics can be used to offload pressure, like to reduce the amount of pressure that you're exerting on your feet as you walk, because they support your feet and basically just distribute the pressure all over, rather than allowing it to be at those high pressure areas that we talked about. I'm going to talk a bit more about that during my segment.
This is a very simple technique that can be used in a low resource setting that is called a Swiss roll technique. It also known, it came up in India, it's known as the Samadhan system. Basically, it was invented to offload patients who had high risk of developing ulcers on the metatarsal heads and the heels. And I don't think we have time, do we, Dr. Shilpa, to show this. But generally what you do is you just, do you want to see this very quickly? Yeah, you want to see it? Okay, Dr. Joy, will you put your foot on the table, please? Okay, well, someone can, does anyone, okay. Does someone want to come over and, Richard? Okay. Right, so I want to show you a very simple technique of how to offload a foot to protect the integrity of the metatarsal heads and the heel. Okay, using a simple crate bandage. Because remember, you can have TCCs, total contact casts, you need to get POP, you need to have Dynacast. A lot of it's not affordable in a sort of first or second level health center. So simply, when we do offloading, so basically, if this gentleman has an ulcer on the metatarsal heads and the heel, so I'm going to draw on his foot. So here. Okay, so let's say there's an ulcer here and there's an ulcer here. How are we going to offload that and that together? Very simply, what you do is you basically apply. So we want to basically offload the pressure of his metatarsals and his heel. So quite simply, we just use a pair of, now if you don't have vet wrap, you can just use another crate bandage. And basically what I'm doing quite honestly is I'm basically creating a rocker configuration of his foot so that we basically offload the pressure to the forefoot and the heel. And basically if you just do that, I think secure it, you can go up the ankle. I'm just going to use all of it because it's going to annoy the hell out of Richard. So we just, and then you basically use that, and Richard, would you stand up please and stand on that. Now you see he's rocking, he's protecting the forefoot and he's protecting his rear foot. So basically that's called a Samadan system or a Swiss roll technique. Very simple technique, can be used in a low resource setting, non-expensive, and you can protect the foot. So remember, during any diabetic foot ulceration or at-risk foot, you need to offload behind that area. And you can do that, like Richard said, with simple padding. And you see how it creates a rocking mechanism, and you're basically safeguarding the forefoot and the rear foot. It's a simple technique, and you can do that. Okay? Great.
Then the no gangrene. Grade 2 is deep ulcer, gangrene of the throat. And 3, when there's expansive ulcer or gangrene. So this is how you classify ulcers. This is a grade 1 ulcer, a W of, in this case, 1. Do you agree with me? How many of you have seen the wound? Okay, I don't have so much to work with it. Very nice question. So it's a very small ulcer, and this person had hardware problems. Okay? So we managed in our center with a simple dressing which helps us to moisture balance, make sure that everything else is in place, the everything is being grouped around the peritoneal area is keeping the skin tidy, there is no maceration allowed. This person is well within the next disease. Okay? I think in this regard, Joy and I had a discussion. Where I have access to things like specialized dressings, Joy in her setting does not have that access. Joy, do you want to tell us something about that?
Okay, at this point, this is a patient with what's at best a very small ulcer with no gangrene. So what you're aiming to do is just prevent the small ulcer from becoming a big issue that you have to deal with later, and trying to break the pathway to amputation. Okay, so basically the basics of wound care will continue to be in use. So, send the patient for dressings, usually every 2-3 days. If it's non-exudative like this one, this is really easy. If there were a little bit of esca around it, then you'd take it off, by which I mean that you might, in some cases, like when Fabian talked about an injury that has a blister over it, you might need to de-roof. But those are, in this case, it's not necessary. So now from the physician's perspective, what you're doing is what caused the ulcer or what caused the injury. The most significant external cause of a diabetic foot ulcer or an ulcer in a patient with diabetes is trauma from footwear. So if this was caused by trauma, then you need to have another look at the patient's shoes. Take out that risk factor. If they need to change their shoes, that's fine, do that. Manage their sugars. If the foot is edematous to start with, and that's why it's prone to skin breakdown, then try and get rid of that edema regardless of, by using whatever means is necessary. By which I mean, if, for example, it's edema due to venous insufficiency, and you might be willing, once this wound has healed, to use compression bandaging or compression stockings, that would be great. If you want to give Daflon to try and assist venous sufficiency, that would be fine. There are a lot of ways that you can try and mitigate it. By the end of the day, there's a low risk wound and easily managed in my experience. I just want to say that where I work, these wounds are a challenge because we don't get to see them at this stage. I'll tell you more about it later.
think this is where, again, it comes in, where, Dr. we have seen you. It's very important to develop this network. I would like to see this person. Lions is not too heavy a center. I'd like to see this person every 3 to 5 days, but this person lives very far away from me. So can we try to develop a referral network wherein I can refer to one of you and we can discuss how the wound management goes so that we're on the same page and we want the same outcomes? Dr. Gugi?
I like this discussion. I had Dr. Kamawi working at Tondo, is that so? What I've known and my training background was that anybody can be taught something if somebody has the capacity to run it. So my practice and what I've seen are that I don't wood, but sometimes I don't have you guys around and I do some wood care myself. And one of the most successful wood care that I saw was one lady, a spouse of a gentleman who had bad ulcers, arterial, septic. For over 15 years, that lady just required instructions written for her and material to be bought. And even today, I do that to those when Colin's not available, he's very far in Karen, and I don't see him. Sometimes those patients who can afford, you write instructions, then there is a nurse or an attendant, and even patient attendants, the instructions are clear, they will follow, then they'll be able to come and see the doctor after a week. So if it's alternate day dressing, they would understand, are you cleaning with saline, you're using this, and then, so I think it's not all lost that we not have qualified podiatrists. It's within ourselves. There are people who this is a trainable issue, so that if the people in the podium there can write manuals or things that we can hand out to patients when we know they can't, so that they follow that, and then you'll be able to follow the progress. Because any doctor again can follow the progress of a wound, whether it's granulating, whether the exudation is less. This is our country, this is where we are. And these are the resources we have. So I think it's to work within our resources, human and material, and I think patients will do well. I have a patient in the ward now, we do not know, she has spent a lot of money, millions of shillings. She came with plantar abscesses, severe infections, she has gone to theater, she lost a toe, vascular compromise, but she has very bad sepsis. She's been in the ward for 2 weeks with plastic surgeons, wood surgeons looking at her foot, but the foot is not good. They are broke, the money is finished, they want to go home. So I think that's where I think where instructions for dressing and material to be used, because then you save money. So that I think it's something that I find it works pretty well in our environment, and in the district hospitals should also work very well. It should be adopted. Thank you.
I agree with you. And one more thing that we can actually consider in this case is telehealth. Telehealth makes a huge impact on wound care management as well. Having said that, I think, have you all noticed that you have oranges on your table? Why? It's not for eating. Please don't eat them. They're not ripe yet. Most of us do not have access to a podiatrist, right? How many of us, although we're mostly in the medical field, don't mind using a scalpel from time to time? Okay, Hilda doesn't mind. Dr. Dara doesn't mind. And I see another couple of hands going up. I want you to get a feel. Dr. Fabian and Dr. Richard will tell you how to go about a basic debridement, and those who are interested can please pick up the blade holder as well as the orange, and go ahead. Most tables have an orange, at least two, and most tables have a blade holder. If you do not have one on your table, please find the one that's next to you, and you can combine and you can try to do the debridement as Richard is going to show you.
So Richard's going to show you a little bit about sharp debridement. Just a simple, you can just use a blade. Sorry, we didn't bring enough handles, but just be careful. You can just take the blade out, an 11 size blade. So Richard, will you butcher the orange?
Okay. Yeah, I'll try not to butcher it. I think that's rather the point. But anyway, so yeah, I actually traditionally we've always used a scalpel handle rather than just the blade on itself. But all you're trying to do is just to gently move the scalpel across, in a patient sense, the top of the skin, and you're just moving it slowly across like this. A lot of patients in the UK will compare this to shaving parmesan. But I think what's important to note at this point is obviously this is an orange, but with the skin on a patient, skin tension is key. If you are just dragging the scalpel over the skin, it will literally drag the scalpel into the skin and then it will cut them. So you need to have skin tension. So it's very much, I mean, for the gents out there who shave, it's very similar. But also, if you are just pulling a piece of fabric like this, if you stretch the fabric, you'll see the creases will start to rise above the rest of the skin, and that's where you then pull the scalpel across. Now we can't do that with the orange, but you also use your thumb and forefinger as to move it with the rest of your hand resting on the patient's foot as a fulcrum. So you're taking small, shallow movements to take bits of skin off. You don't want to take big lumps off in one go. So I'm just going to show you that again on here. So I would be holding the patient's skin with my right forefinger, index finger, sorry, to pull against where the blade is going. So we're taking this very shallow, small areas like this. So if I'm doing it like this, I'm going way too deep, and then you're going to start getting into trouble. So what you really want to do around the margins of the wound is moving it very slowly, multiple times. And it's very important from the debriding point of view around a wound, because you need to remove that hard skin, because it in itself is a source of pressure. Because you're going to get hard skin, callus, over an area of pressure. It's already loaded up. You're now going to get more load on that area because it's now sticking out more effectively. So that's why debriding is the gold standard for any diabetic wound, and also in terms of prevention. Also, making sure the edges of the wound, in terms of the callus, doesn't have a big ridge, because you're again creating a secondary area of pressure effectively with that cliff. So this is why it's really important. It is worth practicing on fruit, and at least if you're using a sterile scalpel, if you get it wrong, then it shouldn't be too bad. Okay.
So thank you, Richard, very much. I think time's up on this session. I hope none of you created a DFU with your orange. So we have some cases that we want to present. And I think
Are you keen on listening to a couple of cases, or do you want to move on with the theoretical lectures? Okay, let's do the cases and we'll go through them really quickly. Yeah, slides please. Sorry, I should have put in, but it's a DFU clinic. It's a Mrs. S, 53-year-old lady with diabetes for the past 4 to 5 years, no comorbids otherwise, on medication, presented to us like this in September. Arv, as a carer, would you let it go to this extent?
No, we shouldn't let it go to this extent. But once the patient presents at the clinic, as a carer, what should I basically do in the home environment? One, to ensure that the wound is healing. What are the telltale signs I need to look out for?
So, from the physician's perspective, that's the role that we play in the MDT, that's at Lions. From the physician's perspective, the first thing that I would look at is the glycemic control. And is there gangrene here? Yes? Yes, there's gangrene there. There is gangrene there. So if I were to classify this wound, I would classify it as a grade 2 ulcer, right? It's a deep ulcer or gangrene limited to toes. It is a deep ulcer. You can see there's extensive damage. What had happened though, and she had come to us with a CT angiogram done. It showed early arteriosclerosis with possibly 60% stenosis of the right posterior tibial artery with cellulitis. Now, to answer Arv's question, yes, what you need, the signs and symptoms of a local infection and a systemic infection have to be briefed to the caregivers. Is this person eating well? Is the appetite okay? Is there onset of fever? Is there swelling and redness and more pain than was before in the area of the ulcer? So these are the red flag signs that we tell the carers about, so that when these happen, you have to bring them sooner than wait for the next dressing. Moving on very quickly. In due course, she underwent a surgical debridement, and we had to put her through a quick surgical debridement because it was pretty bad, and then she subsequently underwent an endovascular intervention. Like I said, privilege. To a certain extent, she had to sell off a little bit of her property to be able to access the money to actually put herself through the endovascular intervention. But we had the possibility. This person was able to afford it. Does that mean that we don't advise other patients and we look at them and say, yeah, you can't afford it, so I'm not going to advise you? No. Your job as the physician is to tell them all possibilities. This is gangrene. This needs an amputation. This is high risk. You need endovascular intervention, and document it in your notes kindly. Medico-legally, we are still responsible. If you don't document in your notes that you've advised vascular surgery, and if this person undergoes amputation and they come back to you and they say, you did not tell me, you're in soup. So documentation is extremely necessary. Tell them. In this case, she underwent an endovascular intervention. Why I like this case is because we tried all kinds of modalities on her. We put her through sharp debridement, always gold standard, over any autolytic debridement, anything else. And Dr. Fabian, you will remember what happened to this next. We put her through a couple of surgical debridements, and then we called in our friends. Who knows what this is? Maggots. We call it larva therapy. These are maggots. Can you see on your left side, the first picture are larvae in biobags. How many of us have used larvae therapy? I know Isaac Maruka is over here. I know he's used it as well. We need his guidance on this. But I have never used free-range larva so far. Sometimes they scoot out of these bags and it's quite scary. But how many of you would be amenable to using larva? Yes, Tara? Nobody else? It was very helpful. Dr. Fabian, do you want to tell them why?
Well, as you know,
remember, we went from this and sharp debridement. We went on sharp debriding this, but then it was not helping. And then our friends came in. She named them her angels. Mrs. S started calling. So we put her through three biobags 3 times of larva therapy. And the wound, the granulation tissue was very healthy. Once the granulation tissue got to this state, we did something called topical oxygen therapy. How many of you have heard of oxygen therapy in wounds? It's coming into being now. Of course, there's expensive equipment, and it's not feasible to do here, but we're doing some research at the Center of Excellence of Lions, and we are seeing to it that we should have this kind of therapy accessible to all of us. So, as you can see, when the wound bed was very, very healthy, we put her through oxygen therapy, of course remembering that the endovascular intervention also did very well. And this is not the same as hyperbaric oxygen, mind you. It's at a much cheaper cost, and it's going to be very accessible. So from November, she healed very, very quickly from November to the 5th of January, and then she went missing. If she did not go missing, we wouldn't even have had that image in March. So this was a very interesting case because we went through all modalities of therapy, and this was a grade 2 ulcer, 2 to 3, I would say, yeah, with ischemia. But we have put her through intervention. This is quickly another grade 3 ulcer where there was there's an extensive ulcer and an extensive gangrene as well. This obviously had to come off. If a carer were to ask me, can we save this? Can we save this toe? No. So do we just snap it off? Yes, I heard yes. Dr. Fabian, can we just snap this off? So, go on.
Cases like this, patients will often present with serious infection, blood work, the inflammatory markers are seriously high, they've lost their appetite, they're not eating, and if you don't deal with this incredibly quickly, you're going to end up setting the patient on wet gangrene, and you'll end up leading to a higher amputation.
So with this patient, he refused to undergo endovascular intervention at the beginning. This led to losing his great toe, obviously, that he was ready to do. And subsequently, as we were dressing, as the wound was still W3, I2, FI2, as you can see, there's a lot of exudate and pus there, and there's a lot of cellulitis surrounding that area. The second toe also had gangrene. So then we were able to convince them that yes, endovascular intervention is extremely important, but we documented it. That's the extremely important part. Document that you've advised intervention. On the 2nd of November, he underwent almost a raise amputation. It looked gnarly like that. And this patient, we also use negative pressure therapy. Negative pressure therapy is also something that does very well with wounds that are gaping like this. And the stump healed well subsequently. We used oxygen therapy on this gentleman as well, and very quickly it closed very well. But now this will remain a high-risk foot, although there is no ulcer, because there is history of amputation. Going back to the non-ulcerative classification and risk stratification, this person is a high-risk foot. So I will ask him, and I have asked him to come every month or every 2 months to come see me. That callosity, Richard, does that need to go? Thank you. And does this, so going back to the Wi-Fi foot ulcer classification, this is exactly what it is. And I want all of us to try to adapt it. If it is difficult to use, there are other classifications like the University of Texas classification, Sinbad, Wagner classification, there's the King's classification, which is also very simple to use. I have only encouraged this because it's great for research, and it's something that's lacking for us here in Kenya. We need to produce more research. So when we do Wi-Fi classifications, we take into account many things, and things that we can do as physicians. Like I said, it's not necessary that you have the Doppler. It's wonderful to have the Doppler where you are, but if you don't have it, feel for the pulses, please. Look at the wounds, even if they're smelly. As far as they don't have maggots going all over, I think we're safe and sound, right? Okay, I'd like to hand over to Joy at this point in time. She's going to give us a brief on how the diabetic foot can be managed in low resource settings. Joy?
Hi. It's nearly 4:30. It's 4:27, and I'd like somebody to remind me at the end of the 20 minutes. You remind me, okay? I don't know whether to say good late afternoon or good early evening, but I hope you're all well. Yeah. Good evening. Good afternoon. Yeah. Okay. So today we're going to talk about the management of the diabetic foot in a low resource setting, and what the challenges are and how we can mitigate them. Okay. So diabetes in Africa and in the Africa IDF region, and specifically in Kenya, is what we're going to talk about. I would like you to take note of a few important things that in the Africa region, that's, you know, in the IDF Africa region, as of 2021, there were 24 million people who had diabetes. And we are expecting that this number will rise nearly 130% by the year 2045. Now, the Kenya diabetes prevalence is estimated to be around 4%, but we know that there still is a high number of people who are undiagnosed. So when they do that estimation, they kind of make the assumption that there's nearly 50% of people who have diabetes have not yet been diagnosed with it. Where I studied, I did my MEd in Alexandria Uni in Egypt, and Egypt is the country with the 10th highest prevalence of diabetes. Their diabetes prevalence is nearly 21.9%. So that's not pretty. Imagine you have 100 million people and 20 million of them have diabetes. It's kind of crazy for me. So this is a diagram showing us the World Bank country classifications by income level. Just by showing you this, I'm pretty much just reiterating what we already know. We're not a rich country. We are, at best, a lower middle income country. And the challenges that we face in Kenya are pretty much cross-cutting, again, you know, across the whole continent, because in that whole continent, there are only 6 upper middle income and 1 high income country. So the Seychelles is where you want to go if you're feeling like you're a baller. But Libya, Gabon, Equatorial Guinea, Namibia, Botswana, and South Africa are doing much better than us from an economic point of view. So when it comes to thinking about the resources that you have and how you can optimize those resources to care for people who have diabetes, then you want to think about kind of the health system as the way I want to talk about it in this situation. I want to talk about it as 2 pillars. So there is the health system itself as an institution. So the hospitals, the facilities, what resources are available at the facilities, and then I want you to think about the patient and the community as a separate entity. I mean, of course, they interact with each other, but when I will talk about Gatundu and being Where's Dr. Wairago? Oh, yes, Dr. Wairago, the current secretary of KUP, is commonly referred to as, for those of you who know her, as the village doctor. And I am now soon to be the village food doctor, because we work in Gatundu, which is a rural setting, and we find that our patients do not have the monetary capacity to undertake the procedures that we would like to do for them, or to help them get the treatment that we would like to offer them, because they are constrained by their personal resources. So I'm going to have you think about it in those as those two silos, where you're thinking about resources at the institutional level and resources at the personal level. So, for example, where again, sorry, I'm going to talk a lot about Egypt because it's again a lower middle income country. I was at Alexandria University, so the institutional resources, you have everything you could possibly need. You have the surgeons, the orthosurgeons, you have the vascular surgeons in abundance. Like you want to do a vascular procedure and Professor so-and-so is going to show up with his team of 6 fellows to do the endovascular procedure, and they're all fighting for it, you know. At the same time, you have equipment above and beyond what you would consider necessary even or available in Kenya. For example, we had Dr. Shilpa was talking about pedography and pedobiography. No, okay. So it's plantar pressure assessment, and Fabian has showed us this on a Harris mat. So where I was, we had this mats and walkways, just like Fabian has at his private clinic. And you stand on it, and it literally draws you that map, the one that he showed you with the green and red. And then you can identify the feet at risk. But then, after doing all these fancy things, then you tell the patient, so I need to offload you, and I need you to put you, in a particular kind of footwear. And they look at you, and you look at each other, and they can't afford it, okay? So at the end of the day, what you have in your facility is pretty much, it's a barrier to affordability, is a barrier to, the patient accessing that care. So the challenges at the institutional level are inadequate equipment and the trained personnel. Of course, that we tend to have a siloed approach to care. In fact, preparing this presentation is pretty much the first time that I had a chance to sit down with 2 surgeons and discuss diabetic foot care. It has never happened. I've been in that facility for nearly a year now, and as much as we meet in the corridors, we hardly ever get to interact, especially with regard to a particular patient's foot. I'll come and see the patients and treat their dysglycemia and the fact that they're not achieving their glycemic targets, and the surgeon will come and do the procedure, and we may never talk, okay? In Kenya, of course, we know we have pretty much virtually non-existent podiatry services. In Gatundu, we definitely don't have them. In Kiambu County, we don't have podiatrists. Fabian was telling me that there are only 8 registered podiatrists, so if you're looking to get into a particular niche of medicine where everything is fledgling, then podiatry is probably one of those places that you want to be. Patients present very late to the institutions for specialist opinion. I will talk more about this as I show you the cases that I have. So the challenges at individual patient level, and I think Arv is going to talk about them, are the 4 A's in healthcare. So is the patient aware that they need help? Can the patient afford the treatment? Is the treatment available at the facility which is accessible to them? Okay, so there I've talked about 2 things as treatment available and can the patient access that treatment? Okay, so there was a study done in Bungoma in Kilifi County, which only, it's focused on 5 public facilities, and they considered the cost to the patient just for diabetes alone. So I'm not going to belabor the point, but where I come from, if you prescribe medication for a patient that's 3,000 a month, chances are that they will skip a few doses. Chances are that, they might try and get an alternative. So you prescribe clopidogrel because somebody has risk of GI bleeding, but then they can't afford that, so they go and get the aspirin. So, you know, these are the challenges that we have. And when you think about the costs to the patient and the family, you want to not just think about what you're doing for them in the hospital on that day, but also the fact that they have to come to you, they have to pay transport costs, they have to eat on the way to and from hospital. They're going to probably need to leave work that day. Somebody's going to come with the patient to hospital. So there's a lot of intricacies surrounding the patient's ability to access care. Of course, there's the intangible costs, which are the patient's pain and suffering. We can't put a number on that. So there are certain elements to preventing, approaching the diabetic foot with a view to preventing the onset of ulcers and to breaking down the chain from, you know, the peripheral neuropathy all the way to diabetic amputations for the reason of diabetes, okay? So in the resource-rich settings, which is essentially what we have these good people here for, and they have a center of excellence, so they have the ability to, you know, auscultate pulses with a Doppler, do an ABI, in some cases do a toe brachial index where the cuff is not put on your ankle but at the toe. It's more specific than the ABI, the ankle brachial index. In Gatundu, I might not have the ability to do that, although I will tell you that this week I am extremely happy because we found a Doppler lying somewhere in the store. I can't wait to go back. So what we've been doing instead is we palpate pedal pulses. Are they present? Are they strong? Or are they, you know, difficult to palpate? Or are they non-palpable? So whereas you might say, when you try to grade ischemia and you're saying the ABI is 1 or 0.9, which is good vascularity, at that point you want to or expect to feel the pulses in good health, nice, strong pulses. Thereafter, as the ABI goes down, then you might find difficult to palpate pulses, and then they progress on to non-palpable pulses. Okay, so of course the other thing you want to check at all times is the capillary refill, because you might have pulses, but at the same time the patient is not really at the microvascular level. They're not perfusing, as best as they could. So when it comes to, does it have a pointer? Okay, so I'm going to go down to the back. Okay, so here we are in the resource-rich settings, and it's crazy to me that I put this way, that the 10-gram monofilament, the little gadget that you're going to get, it's simply a tiny piece of nylon filament. And in Gatundu, or in public facilities, because I have tried, you have to physically go out and look for it. It's not readily available in the clinic, yeah? So, you have that, what would cost you maybe 200 shillings, 300 shillings, it's hard to come by, not because you don't want to get it, but it's literally not available. Okay, so we also do vibration perception thresholds. What is a VPT is at what threshold can a patient perceive vibration? So when you use a tuning fork, you can't really assess, at what threshold they're perceiving it. But there's a gadget called a vibrational thesiometer or a biothesiometer, which actually counts for you and gives you a grading from 0 to 100. At what point is the patient perceiving vibration? So for you, many of you at least, I would hope that your VPT threshold is less than 15%, which makes you a low risk foot. And by the time you get into 25, as long as you cannot perceive vibration at a level over 25, then essentially what we're saying, you have a very high risk foot for ulcer and for amputation. So in the resource limited settings, what we're doing is we're using the diabetic neuropathy symptom score. It's a simple series of questions. Okay, do you have numbness in your feet? Yes or no? If they say yes, then you score 1. Do you have tingling or prickling sensations in your feet? If they say yes, you score 1. Do you have unsteadiness when you walk? Yes or no? Do you have an aching in your calves or in your feet, or a burning sensation in your calves or your feet? So if you score more than 1 out of 4, already you have clear symptomatology of diabetic neuropathy. Now, I'm not going to go into I think because of time limitations, I'll not go into what's the definition of probable neuropathy, possible neuropathy, and confirmed neuropathy, but it depends on the level of institutional power that we have, the equipment that we have that we can afford to use. So a simple test for assessing whether somebody has neuropathy, if you don't have a 10-gram monofilament, is simply an Ipswich touch test. So you take your finger and you touch the patient's big toe, middle toe, small toe, and if they can feel that, then they don't have the signs of neuropathy, so they don't have loss of protective sensation. You also need to do anchor reflexes. Why anchor reflexes? Because, so the absence of anchor reflexes or the presence of impaired anchor reflexes denotes a very high risk foot, which is at risk of diabetic foot ulceration. So you want to keep a lookout for that. Do not ever do a foot exam without a patella hammer. Again, a tuning fork for vibration perception. It's extremely subjective, but if the patient can't feel it once you've struck it and you put it on the bony prominence on their foot and they can't feel it, then it's just too bad. At that point, you pretty much have confirmed that their vibration perception is off. Okay, so this I'm going to come to later, the home-based thermometry, when Fabian and I are talking about Charcot foot. But basically, what do you tell the patient about when they should come to hospital? One of the things you want to tell them is, come to hospital if you have a warm foot. So of course they'll tell you, my foot feels hot. But in places where we have the ability to, patients will have an infrared thermometer, just the little guns, the temperature guns, and every evening they will check the temperature in both feet. And if it's more than 2 degrees between, it's called the rule of 2s, 2 degrees between 2 feet on 2 days, then they will come to you and you can intervene before you have a diabetic foot ulcer. So amongst other things that we do for prevention of diabetic foot ulcers is the inspection of high-risk feet. So I want to tell you that, to be honest, our clinic has so many patients. Like the patient load, you can see 40, 50 patients. If you're alone, you can see maybe 12, 15, 13, and you're trying to see these patients who have a lot of comorbidities. So quite often we won't tell them to please take off their feet, their shoes, or their socks. But that foot care should be, foot examination should be a routine part of diabetic foot care according to the time spaces that Dr. Shilpa has given: 1 month, 3 months, 6 months, or annually. The challenges to that in where I work are staff shortage and inadequate time allocated to do these examinations. The mitigation for this, in my opinion, it could be something as simple as asking the triage staff to tell the patients that, look, you're going into the doctor, please take off your shoes now, okay? Take off your shoes and socks. Okay, it helps a lot. And of course, as we have been taught about the 3-minute foot exam, it saves you quite a bit of time. So structured education, educating your patient on safe foot care practices is really important. So this first study in Gatundu was done by Dr. Wairago and Dr. Isabella, and they pretty much assessed the knowledge, attitude, and practices of patients with diabetes, and discovered that nearly 94% of them did not know how to regularly inspect their feet. That same, they didn't even know what appropriate footwear is, 25% of them. And I'll tell you that what we think we know about footwear and what's appropriate footwear, there's a lot more that goes into that story than we actually do. So if as healthcare practitioners today, we're talking about what's good footwear, I can almost guarantee you that 23% translates into maybe 70% when you do a real thorough examination of the patient's footwear. So in Egypt, we had inappropriate footwear of nearly 90%, and the same thing carried through in Tanzania. So I want to talk about the reason for, that, sorry, it doesn't point, but the appropriate footwear is really important because a lot of patients in the rural setting or in the limited resource settings are patients who do things like farm for their occupation. They are border riders, they are drivers, they're basically doing physical tasks, and a lot of them will be doing these physical tasks in shoes that are inappropriate. So this is a patient that I saw at the Diabetic Foot Clinic in Egypt, and as you can see, their shoes were really good, like the idea behind the shoes are good, but they were rubbing against the patient's second toe, and they ended up with a subcutaneous erythema, small hemorrhage, and then when you took it off, it actually turned out under there was a small ulcer developing. Thankfully, we were able to, to heal it. So you basically need to tell your patients what are good shoes. And as Fabian told us that it's easy to find good shoes for men, it's harder to find good diabetes appropriate shoes for ladies. Most of us want to look pretty, and it's really, really hard to get them in the right shoes. So these are examples of shoes that I just, took off patients' feet. And I have to tell you that these are not the worst of them. I've seen pretty bad stuff, including patients who walk around barefoot at home. But, when the shoe looks good from far, and then you take a closer look, and it turns out to be, is it far from good? Yeah, so that's a concern. Now, you also need to treat risk factors for ulceration and pre-ulcerative lesions. Here, we have a bleeding recurrent fissure. It used to bleed every now and then, and the patient was quite comfortable. You notice he also has ingrown nails, but when he came to us, we recognized it as a risk factor for diabetic foot ulcer and debrided it, and ultimately that area healed. Same goes with the callus. I'm not going to belabor the point. Rich has shown you how to do it. So basically what you want to tell the patient, again, it's educating the patient is everything. You tell the patient that if you have anything new on your feet, please come and see us. If your feet are warm, please come and see us. And in the meantime, as you make plans to come and see us, stay off your feet for as long as you can. Now, a challenge I have, is somebody knocking? A challenge I have quite often is that by the time patients come to see us, they've already attempted self-surgery. So this is something that you really want to talk about with your patients. So, all right. So amongst the mitigations that we find, patients don't come to us with grade 1 or grade 2 ulcers. As I told you, they come to us when things are pretty bad. So I'm going to show you a bit of that. They usually come to us when their diabetic foot ulcers have been infected, and then we end up with limited formulary already, which is inconsistently available. And the challenge is if they've already come and they've tried amoxiclav and clindamycin, then you're being forced already to go to ceftriaxone and metronidazole. If that doesn't work, you certainly can't find, or you have trouble finding piperacillin tazobactam. So that's a concern for us. When it comes to surgical intervention, again, just because of the late presentation, we end up doing really extensive debridements over and over again. A lot of times we have to do amputations because we don't have a choice. And the strange thing is, please note the number of weeks the patient is admitted. The minimum length of stay for somebody who goes direct to amputation is 2 weeks. But if we try limb conservation, we end up, having a longer length of stay, and sometimes this results still in an amputation. So that's a concern. The challenges to effective wound care are the same ones that we already know. We have a shortage of nursing staff and wound care nurses. We only have one, for example, where I work. And of course, that requires training. We have concerns with home-based versus facility-based care, wound care. If a patient doesn't know what they ought to do, but if you can teach them what they ought to do, they can do it. And of course, we have a limited choice of wound dressing. So I don't have any of the fancier dressings. There are cellular matrices and this. Okay. So I'm not going to talk about limb offloading because Fabian has talked about it and Rich has demonstrated it. I just want to, bring two cases to your attention. This was an 89-year-old frail male patient who presented with a diabetic foot infection, which we found to be so extensive that it was actually in his thigh compartment. At this point, there was no opportunity for revascularization or trying to save the limb. It was just necessary to just amputate, and unfortunately we had to do that, but the patient did well and the stump healed properly. This is another similar case. Now I want to point out that image number 5 and 6 we hardly ever see because the patients, we don't examine them in the DCC, and when an injury happens and it's small, they don't come to us at that early stage. So making this presentation was really sobering. I saw a lot of gaps that I never thought about. I never thought about the fact that patients come to the DCC, the diabetic clinic, with normal feet, but then when they get an injury, they don't come to us, so we only see their wounds when they're deeply infected and extensive. So success means different things in different settings. For me, to be able to get a patient back on their feet without necessarily doing an amputation is great. But if in a situation where I don't have a choice, the amputation is what keeps them alive, then that's what we do. So we see a great need for a multidisciplinary approach, for patient education, for, of course, basic equipment, and for staff training. So in your opinions, does that look like success? Yeah, all right, thank you.
Thank you very much for that insight. It's extremely important. I'd like to apologize to our attendees. We'd have to forego this talk. I apologize to Arv, but we will make these slides available to you so you may understand the very important administrative aspect of integrating podiatry and multidisciplinary care. But I will hand over to her in regards to a couple of things that she needed to say to us. Thank you.
Thank you, Dr. Shilpa. So as Dr. Shilpa has mentioned, these slides will be made available to everyone, and I apologize that I was not able to present them to you today. But I wanted to mention about the Foot and Limb Group Association. Our chair is Fabian Collis, and our vice chair is Richard. And this association is all about saving the limb and education and patient education. We are also educating through symposiums and webinars aimed at not the healthcare professionals, but also aimed at patients. And we'll be celebrating our 4th annual symposium in October, which is now coinciding with Podiatry Day on the 8th of October. But the symposium has been penciled in for the 5th of October. We just need to lock down the venue. And we would like to invite all of you to attend that. It will be in Nairobi. But it will be full of workshops and practical demonstrations like you've seen today, and we are coming up with the theme, and we'll be able to share all of that with you. Would you like to add anything to that, our chair, Fabian?
Just to say that thank you very much. I know we've run out of time today. I know you guys have probably got painful feet sitting there and need to get the blood flow moving again, and go for a swim and a walk. And I just want to thank you all for being so patient, and thank you to Kdsg for giving us so much time today. I know we're all a little tired and we're a little bit hypoglycemic, so I want to thank everybody. And I want to just say, take-home message from me is basically, if your feet feel right, then you feel right, and then everyone else around you gets a chance. So please look after your feet, because if you look after your feet, they'll look after you. Dr. Joy, do you want to take home message?
Oh yes. It would be the one I said, get your patients or their carers to check their feet every day and get to know what's normal. And when it's not, find somebody to talk to about it.
Look at your feet before you sleep. Tell the patients, your PWDs, to take a look at them every day. Multidisciplinary approach is extremely important. And I'm so sorry, but you're supposed to do a post-test as well, kindly. Thank you very much. Do we have any quick questions? Or you can post them to us. If you visit the Falga booth, I'm sure you'll be able to eventually get in touch with us. Slides, please. Thank you. Did you get the post-test picture?
Can I ask a question, Dr. Shilpa? As people do the post-test, two questions. One, is there such a thing as prophylactic orthotics? Like now with Betty's shoes, can she just put something and then, like, you know what I mean? Trying to eat your cake and still.
I know.
Yeah. So then the second question is, I had a patient a few weeks ago, and the orthopedic surgeon almost did a BKA for this patient. But we called in the plastic surgeon, and he was able to save the foot and do vacuum dressing and all that. So my question is, do we have clear guidelines in Kenya? Because I felt a bit, it was very difficult. One day you're telling the patient, oh, your foot is coming out. Then the next thing, no, the foot isn't coming out. So what guidelines are helping the surgeons make these decisions, and are they in the Falga Association? Is there a collaborative approach that the orthopedic surgeons and plastic surgeons have? Those are just, because I've seen there's a bit of confusion with the care. Thank you.
Okay, thank you for that. Falga, we have sort of been given a mandate to help improve podiatry care in Kenya, not only at an FHP level, a foot healthcare professional level, but also to do sort of set up eventually an undergrad podiatry program, degree program for Kenya, and make it Kenyan-centric and make sure that it works here. I think, yes, we are planning to do guidelines for diabetes in the foot. I know that with Kdsg, and thank you so much, they've sort of mentored us and with a baby. So we're trying now to sort of help to see how we can discuss with them and come up with guidelines for the diabetic foot. And yes, there is a study. I know that the new guidelines will be introduced tomorrow. And I think that generally it's about looking at podiatry in a sort of different aspect, making it more accessible, and making sure that Falga sort of takes that on and changes people's mindset into sort of limb salvage. So yes, and regarding your other question on offloading the insoles, yes, you can wear a basic generic insole and it might help, but generally patients who are diabetic with serious diabetic complications need special prescription orthotics to be done to mitigate any form of ulceration developing later on. Anyone else to add to that?
No, nothing. I believe Wound Care Society have just recently released guidelines, but I haven't had the pleasure of taking a look at them, and I should. We should. I think with that, we're winding down, but then after everything, just before you go to tea, if you are very interested, you could come over and we can show you the orthotics and everything else that we have. And thank you very much for patient listening. On behalf.
Thank you. Yeah, you take a photo for the. Let's give them a hand, please.
Thank you very much. Thank you.
Let's give them another hand, please. So thank you so much to the foot team. Unfortunately, we're not able to get all the information they wanted to give us, but we are very grateful for what they presented to us, especially for the demonstrations that we had. So a couple of announcements before we break. First thing is that tea will be served at the booths, so please pass by even as you go through the booths. There's tea served there with a few snacks. And then tomorrow is
very special day. It will be a busy day, lots of things to learn. So